Welcome to my IBD Learning virtual program, Endoscopy and Colonoscopy in Inflammatory Bowel Disease. Endoscopies play an important role in the diagnosis, management, and treatment of inflammatory bowel disease in existing diagnoses, differentiating between Crohn's disease and ulcerative colitis, monitoring disease activity and response to treatment, and assessing for and treating complications. There are a variety of different types of endoscopies that can be recommended today. And today I'm going to share with you a bit more about these tests and explain how they can help you or your loved one achieve remission goals. My name is Dr. Shannon Chang. I am the Clinical Director of Operations at the NYU Langone Health Center for Inflammatory Bowel Disease. This information today shared is meant to be for educational purposes only and should not replace any advice or guidance from your healthcare professional. Here are my personal financial disclosures. The Endoscopy Initiative is generously supported in part by Intuitive Surgical and Medtronic. So what is a endoscopy? Endoscopy is a major part of how we diagnose and treat inflammatory bowel disease. In general, endoscopies look inside or endo and using a scope to examine the gastrointestinal tract. The endoscopy is a flexible tube with a light and a camera that we insert into the body to look for abnormalities, including things like inflammation, which might be ulcers, erosions, or bleeding. We classify the severity of the inflammation or inflammatory bowel disease, and typically that can be graded as mild, moderate, or severe. And then we look for complications such as narrowings or strictures in the colon or small intestines. And we can also see complications such as narrowings or strictures in the colon or small intestines, and other things such as abnormal connections, such as fistulas, which are tunnels between one point and another, or one organ and another, between different parts of the gut and other organs. There's a few reasons that your doctor may ask you to undergo an endoscopic procedure. That might be to confirm your initial diagnosis of inflammatory bowel disease, or to differentiate between Crohn's and ulcerative colitis, to assess response to a treatment that you have recently received, to evaluate any active symptoms to help differentiate between active inflammation and non-inflammation symptoms, and also to check for precancerous changes or dysplasia in your colon. There are six main types of endoscopies in inflammatory bowel disease that you're going to encounter for the most part. This is an upper endoscopy, which is referred to also as a EGD or esophagogastroduodenoscopy, colonoscopy, which looks at the colon, flexible sigmoidoscopy, which just looks at the end of the colon, a pouchoscopy that looks at the J pouch, which we'll talk about a little bit later, capsule endoscopy, and ileoscopy. The upper endoscopy, or also referred to as EGD, examines the upper GI tract. So it looks at the esophagus, stomach, and the first part of the small intestines called the duodenum. And it looks at the first and second part of the duodenum. Usually an endoscopy lasts 5 to 10 minutes. Usually all patients receive anesthesia or sedation. This upper endoscopy is typically included in a Crohn's disease workup, but not usually in ulcerative colitis, and it evaluates symptoms of upper abdominal pain, nausea, vomiting, acid reflux, diarrhea, and dysphagia, which is also known as problem swallowing. A colonoscopy looks at the entire colon, which is also referred to as the large intestines, and at the end of the terminal ileum. Most patients do receive anesthesia or sedation for colonoscopies, and all patients will require what's called a prep or a bowel preparation to cleanse or clean out the colon. A colonoscopy is included in all Crohn's disease and ulcerative colitis workups, and it evaluates symptoms of diarrhea, frequent bowel movements, urgency, blood in the stool, and abdominal pain. Moving on, a flexible sigmoidoscopy is an abbreviated or shortened version of a colonoscopy. It only looks at the end of the colon, which is usually just the left side of the colon, so the rectum, the sigmoid, and the descending colon, sometimes the transverse colon. This helps diagnose IBD, but also to monitor response to treatments, particularly if your inflammation is always just at the end of the colon, then a flexible sigmoidoscopy may be appropriate in certain circumstances as opposed to a full colonoscopy. The prep for a flexible sigmoidoscopy varies, but usually just involves enemas to empty out the very end of the colon. A flexible sigmoidoscopy, or flex sig as we like to call it, lasts about 5 to 10 minutes. And because it's such a short procedure and just looking at the end, sedation is optional for these. A pouchoscopy is for ulcerative colitis and some Crohn's disease patients who have had their colon removed in a surgery called a colectomy, and they have repurposed the end of their small intestines, the ileum, into something called a J pouch or a ileal pouch that is created through a series of surgeries. The pouchoscopy will look at the ileal pouch and the ileum above the pouch. It usually involves for prep, sometimes clear liquids, but mostly just enemas for the patients. And then it lasts about 5 to 10 minutes. And sedation for these is optional, but most patients do opt to have sedation. A capsule endoscopy looks at the small intestines that you can't see or reach by the conventional upper endoscopy and colonoscopy. For a capsule endoscopy, it is where a patient swallows a tiny pill with a camera inside, and they wear a recorder around their body until the test is finished to capture the images that the capsule takes. The pill, in usually a day or two, will come out in the stool. It does not need to be retrieved because the images have already been saved and returned to the doctor for processing. An ileoscopy is for patients after surgery who have what's called an ileostomy, which is a stoma, as you can see on the right, that the tissue, when you go in, is actually the ileum. And so the ileoscopy looks at the ileum. Prep for this usually only involves just being on a clear liquid diet. The ileoscopy lasts about 5 to 10 minutes, and sedation is usually given because there can be a little bit of discomfort. So those are the 6 types of endoscopy. Now we're going to talk about common procedures that might happen during an endoscopy. So the most common procedure that's going to happen during an endoscopy is a biopsy. And biopsies are tiny little tissue samples that are taken during the procedure. The biopsy is the size of the tip of a ballpoint pen. They're very small but informative, and they help us look for inflammation, early changes that could lead to cancer, also termed dysplasia, and any other problems or indications for why someone might not be feeling well, including injury from medications such as NSAIDs, poor blood flow, which is also known as ischemia, and sometimes we can also pick up signs of infection. These biopsies, after they're taken, they are put in a jar and then they are sent to the pathologist to be processed and then analyzed. After a biopsy, you may see a little bit of blood in your stool. If it continues for multiple days after the procedure, you should contact your doctor just to ask if this is still normal. Other common procedures during endoscopy include chromoendoscopy. Chromo literally means color. So you're using techniques to improve imaging so that your doctor can see better inside. So the typical chromoendoscopy involves actually spraying a liquid dye onto the colon lining to highlight and detect abnormalities such as polyps or other precancerous changes. Typically the dye is blue. So after you have your chromoendoscopy, it's not unheard of to have blue or greenish bowel movements and possibly greenish urine following the procedure for a day or two, but it goes away on its own, and this is expected. For virtual chromoendoscopy, the doctor is actually going to use imaging technology and filters on their colonoscopy scope to find abnormalities in the colon lining. So there's no need for that dye spray, so you wouldn't be seeing the changes in color in the bowel movements or urine afterwards. Another common procedure during endoscopy is a balloon dilation. This is where someone has a narrowing called a stricture somewhere in their GI tract, where the doctor can go in with their scope. Through the scope, they can actually put a wire that has a deflated balloon at the tip. Once they get to the stricture, they can pass that wire through the stricture or narrowing and then use air or water to blow up the balloon to help try to stretch open the area that is narrow. Another procedure during endoscopy is a polypectomy, where you remove polyps. So, what is a polyp? A polyp is a growth in the colon that could happen for multiple different reasons. And of course, there's different types of polyps involved. Sometimes we can clearly tell, for example, that it's a inflammatory polyp, and we don't need to remove those per se. But there are some polyps that we do need to remove because we are concerned about them. And so what we do is sometimes we will either use biopsy forceps or, as you can see in this picture, a loop called a snare that will help us remove these polyps. So when you're preparing for your colonoscopy, it's important to know that the key to success is having a clean colon so that your doctor can see clearly the lining of the bowel. And that's to look for polyps and to look for inflammation, ulcers, bleeding. And it really helps us get a better view, and the procedure actually goes faster if the doctor can see better. So, 2 weeks before your colonoscopy, please review the colonoscopy prep instructions, read them through one time, circle any questions that you have, and contact your doctor to ask for clarification. Special considerations that are very important before your colonoscopy or endoscopy is to talk to your doctors about blood thinners that you might be on, including Coumadin or warfarin, Lovenox, apixaban, and dabigatran. Baby aspirin is okay to continue throughout the procedure. And then the other types of medications that are being increasingly used now are the GLP-1 agonist medications for diabetes or weight loss. Those medications can slow down the movement or motility of your GI tract. And so there are special requirements for how long to hold those medications. For the injectable medications, usually the GLP-1s have to be held for 7 days. So please, if you're on any of these medications, reach out to your GI doctor for clarification for how long the medications need to be held before procedures, because this affects the anesthesia's plan. 1 week before the procedure, you want to stop certain supplements that can affect your prep. So you want to stop iron, which can make the stool dark and also cause constipation, and then some of the oil-based supplements, including things like fish oil and vitamin E supplements. 5 days before the procedure, you want to start avoiding things that are going to be hard to clean out. So things like nuts, seeds, raw fruit with skins, raw vegetables, the leafy greens, beans, and whole grain bread with nuts and seeds encased around them. Please note you want to always follow the specific instructions provided by your gastroenterologist. There are lots of different types of bowel preps available today. So you should talk to your doctor about one that works for you in terms of your preferences. But in general, we have multiple pill bowel preps now. We have liquid bowel preps at various volumes of liquid. So if you're someone that can't drink a 4-liter prep, then there are smaller volumes available now. And then there are also powders. The most common powder prep is going to be some variation of polyethylene glycol 3350, also known as PEG. This is the active ingredient in a lot of the different preps. So, another important thing to say is if you have in the past had an inadequate bowel prep or a dirty prep, talk to your doctor about what happened last time and solutions to avoid that happening again. Sometimes we start the prep earlier, sometimes you might need a multiple day prep, but your doctor should be able to brainstorm with you about what makes sense for to try next. How to make the bowel prep easier. So, tips and tricks from doctors who have been doing this for a while. Patients note that if the prep is cold, so either refrigerating it or drinking it over ice, it can be easier. Drinking through a straw makes it a little bit more palatable if you don't like the taste. And Most importantly, if you start to get nauseous, really try to take a break and not chugging it before trying to drink more prep because sometimes that can lead to worsened nausea and sometimes vomiting up the prep. There's a specific type of prep called a split prep, and a lot of doctors do use split preps because it tends to clean the colon better than drinking all of the prep all at once. So, in general, the split prep involves drinking half the prep the evening before the colonoscopy, and then after a certain number of hours, taking the other half of the prep so that it helps the colon clean out better. Please follow the instructions from your doctor about specific timing of that so you can make sure that it works well in advance of your procedure and in advance of your travel time. What can you expect during the bowel prep? Well, you're cleaning out the colon, so there's going to be frequent watery bowel movements. This may cause a little irritation. It may inflame hemorrhoids, and because of the frequent wiping, the skin around the anus may become sore. Some bleeding is possible if you have existing hemorrhoids, so you want to keep, either a zinc oxide barrier cream or potentially like preparation H at the bedside if you have it for soreness during the prep. Possible other symptoms, we discussed the nausea before, and then because we are promoting bowel movements, there may be mild abdominal cramping. How do you know if you're done prepping? Well, the goal is going to be a clear yellow tinged stool, which I say is like the color of urine. So in the pictures on the right, sometimes people start at 5, which is that dark and murky brown. And then at the end, once they're fully prepped, you can see it's yellow and clear like urine. In picture number 1, you're ready to go. So you go and have your colonoscopy, then afterwards, what can you expect? So after the anesthesia and sedation from the colonoscopy or endoscopy, a friend or family member needs to escort you home. You're not supposed to drive or operate any heavy machinery for the rest of the day, and you want to avoid heavy lifting or strenuous activity for the rest of the day because some people might feel a little weak or lightheaded. The day after the procedure, you can resume your regular activity and diet. After biopsies, again, you may see small bouts of blood in the stool, and you might feel some residual prep effects. So you might feel some cramping, trouble passing gas or stools, some lightheadedness and fatigue, but this should go away within 24 hours of the procedure. And if it doesn't, you should call your doctor and let them know. And then you want to avoid alcohol for about 24 hours afterwards because you did receive anesthesia. Endoscopy is part of our goal of improving IBD care and outcomes through something called treat to target. So, treat to target is to treat the patient and then try to assess our response. So, what kind of responses are we looking for? We're looking for symptomatic response. How do you feel? Do you feel better? What symptoms are doing better? We also want to see improvement in your biomarkers. So, common biomarkers that most doctors will check for ulcerative colitis and Crohn's patients include C reactive protein, fecal calprotectin, and in some cases, ESR. And then we also want to look at the target of improving or completely getting rid of inflammation in the bowel lining. So, your doctor is going to assess this disease activity and symptoms before and after starting a treatment. And if they're not happy or they haven't achieved the target of remission, then they might suggest a change in treatment or alteration of a treatment in order to achieve their target of these specific goals. The long-term goal of IBD treatment is going to be remission. So a lot of my patients will say, what is remission? Well, there's different types of remission. So one is clinical remission, where your symptoms are controlled and you feel well. And then there's endoscopic remission, where there's no active inflammation when you look on the endoscopy. And again, endoscopies help us to achieve these remission goals because we're proactively saying, okay, well, you feel well or you feel pretty good, but how does it actually look inside? And do we need to make any tweaks or changes to your medications to try to get you to the best that you can be? And it also helps us tailor a patient's treatment to achieve that remission. Another important part of endoscopy is colon cancer screening and surveillance. So, patients with involvement of the colon with the inflammation greater than 1/3 of the colon, have an increased risk of colon cancer in their lifetime if there is ongoing active inflammation. So there are guidelines for who should have colonoscopies more frequently for dysplasia monitoring, and that is patients with either ulcerative colitis or Crohn's disease for 8 years or more, with at least a third of their colon involved, or also patients with primary sclerosing cholangitis or PSC, which is an autoimmune liver disease. Patients with PSC have a much higher risk of colon cancer over their lifetime. So for PSC patients, the recommendation is to get a colonoscopy every year. And that I will say that's every year from the time of diagnosis. The frequency of how often you have to have a colonoscopy for monitoring for dysplasia, aka surveillance, depends on your risk factors for dysplasia. So talk to your doctor about that. But in general, if you have long-standing inflammation, if you've had ulcerative colitis or Crohn's disease for many, many years, or if you've had prior dysplasia, then you're probably going to get colonoscopies more frequently than someone who has not had the same risk factors. As our program comes to an end, on behalf of the Crohn's and Colitis Foundation, we encourage you to keep learning about IBD and to visit our helpful educational resources. To learn more about diagnostic tests, in addition to endoscopies such as blood, stool tests, and radiology exams, visit the Foundation's website below through the QR code on the left side of your screen. If you're looking to learn more about how IBD impacts the entire digestive system, I encourage you to check out the Foundation's GI Tract Guide, which is an interactive tool to learn more about your organs and how they may be affected by Crohn's disease or ulcerative colitis. This can be accessed through the QR code on the right. For more information on medications, check out the IBD Medication Guide. This guide allows you to filter and sort medications based on options such as disease, drug class, and preferred method of taking medication. If you're looking for information about the reasons why surgery may be necessary, as well as the different types of surgery that may be recommended, we encourage you to check out the following web pages on surgery for Crohn's disease or surgery for ulcerative colitis, which can be found at the QR codes on your screen. In summary, endoscopy in IBD is used to evaluate severity, inflammation, extent of IBD, and complications. A good bowel prep is essential so the doctor can see the bowel wall lining clearly. Endoscopy is an important tool for physicians to understand a patient's IBD and response to treatment, with the ultimate goal of treating to the target of remission. Finally, colon cancer monitoring or surveillance is recommended for IBD patients who have had inflammation in the colon. This could be both UC patients and some Crohn's patients, and disease duration more than 8 years. On behalf of the Crohn's and Colitis Foundation, thank you so much for tuning in today to learn about endoscopy. For more information on the Crohn's and Colitis Foundation, please visit www.crohnscolitisfoundation.org. Have a great day.